one presentation to go, and so we saved the best for last. You don't have to feel bad. It's okay. But Dr. David Bushnell is a nuclear medicine doctor, so he's got the cool stuff to talk about, Lu-177 and PRRT kind of things. So with no further delay, let's give a big round to Dr. Bushnell.
Thank you. This is the point. That's the thing. Will that advance the slides? Does this advance the slides?
Sorry, I didn't wait for our AV to catch up.
We good?
Yep, I think we're good.
Let's just try it.
There we go.
Okay. Well, so nice to be here. Thank you always to Bob and Marianne for the invitation. These are terrific conferences, and it's really nice to be part. It really is. Following a great talk by Dr. Mohammed, a little bit of overlap, but you know, focus is going to be on radiation-related treatment, targeted radiation. But, you know, before we start, Dr. Howe and I are from the great state of Iowa. You've flown over it many times. And been there a few years. I think, Jim, you and I started in the 90s sometime. Oops. Oh, down. So we're known for corn and for pigs, hogs, and there we go. And then, of course, I'm known throughout the state as an accomplished dancer. My daughter here on one of the beautiful beaches in Iowa. All right, so we're going to talk a little bit about targeted radionuclide therapy, and then, you know, more specifically PRRT, which is peptide related that you're all, I think, very familiar with, targeted therapy. And so to start with, a little physics. Everybody remembers where the beta particles come from. These are the electrons that shoot their way out of the nucleus of a radioactive atom, and it's a process where you've actually got the neutron conversion to a proton, and so to conserve charge, one of the fundamentals of physics, you got to have an negative electric particle come out, and as a consequence, that's where we get the beta particle from Lutetium-177 and Y90. And then, of course, the idea is the beta particle strikes, if we can get it to the tumor cell, it strikes the cell, and eventually the cell dies from a variety of different mechanisms. Here's the schematic that I've shown over the years. And of course, you see the FDG receptor on a neuroendocrine tumor cell. Remember, PET FDG is something, an imaging procedure some of you may be familiar with, and touch on that in a little bit. Some of you may also know about PET imaging with fluorodopa, which is a radiopharmaceutical that targets most types of neuroendocrine tumor cells very well, but it's not an FDA-approved agent. Some centers do have it on IND. But then, of course, the wonderful somatostatin receptor, and that's the site where the octreopeptides, and in this particular talk, the radioactive octreopeptides bind and then deliver those beta particles to the rest of the cell. I'm going to mention MIBG as a targeting agent. In this case, the radioactive substance is an iodine. It can be different nuclides of iodine. 131 is actually the beta particle emitter that kills the cell. These are imaging appropriate radioisotopes. And the receptor, and this is sort of important to whether or not there'll be value in using MIBG for neuroendocrine tumor treatment, is that the receptor is not the same as it is for the octreopeptide. And there are cells out there that don't have octreopeptide receptors, they don't have somatostatin receptors, and yet they do have receptors for MIBG. So some of the work that we've been interested in doing, and I'll mention a little bit. So, oops. So the concept of targeting a cancer cell requires, you know, the kind of understanding that you've got this cancer cell target right here, and then the targeting molecule, and that's the octreopeptide for the most part that we're going to talk about today. And then there's this linker molecule, which is sort of a big deal, and radiochemists and chemists change the linker molecule and are in the process of studying how changes in the linker molecule improve the ability of, in this case, let's talk about octreopeptides, to bind to the receptor on the tumor cell. And then the chelator molecule, which is this thing here, will bind the radioactive metals. And if we go a little further, you can see the nice little movement there. And let's go and see some of the metals that we're familiar with, and they're sitting in that chelator, yttrium-90 there. And of course, most recently, and some of you may be familiar with the copper-64 PET imaging agent that in some cases, some centers like ours, is using instead of the gallium agent that we've used for many years, of course. Copper-64 has some minor advantages. DetectNet is the trade name over gallium octreotides. And of course the imaging moiety for if you're interested in the chemistry, and you may know this, but here's the whole Lutathera molecule, and off at this end are the two amino acids that actually do the binding to bring the lutetium target, the lutetium radioactive substance. These two amino acids do the binding to the receptor. And so, as you're familiar, you know, here's an example from a few years back. This is the gallium-68. In this case, I think it was Dotatate, octreopeptide PET. And this was so then the patient's treated with Lutathera, and we actually are able to make images with Lutathera. They're not as good. See, I mean, you can kind of tell that this image is not as highly resolved, this Lutathera image. Look at the kidney here, for example. You can see the outer cortex of the kidney on the PET study with gallium, but the kidney over here, pretty blurry. But the blurriness and the lack of resolution for the purposes that we use after Lutathera imaging doesn't matter so much. These, we'll touch on it a little bit later, these images are used for dosimetry purposes and not really for the same reason that we need these high resolution gallium images. So the ability to do post-therapy imaging with Lutathera is really valuable for dosimetry purposes. So the phase 3 trial, Dr. Muhammad, did a very nice job summarizing the big phase 3 that ended up in the publication in 2017. I think everybody, of course, is familiar with the results It's hard to believe it's been that many years. The trial started, 2013, 2014, and summarize the results already, so I won't spend a lot of time on it. You saw these important graphs indicating, in this case, progression-free survival, the advantage of Lutathera over the high dose of sandostatin. Now, recently, Dr. Strasberg published, I think it was last year, we'll just go on. Well, let me show you this case. This is one of the very first cases enrolled in the NETTER-1 trial and this was from our center, and you can see this. So here's an axial image, same just like these CTs, but this was even before PET, or before gallium. So this was the old, remember the old Octria scan. This is the indium-111 image. It wasn't a bad image, really, and you can see, so here, look at this tumor. This is the pre-treatment CT, and then here you can see the dark high targeting that the Octrio scan told us, hey, yeah, this patient is eligible for this new NETTER-1 trial. And then lo and behold, after the treatment cycles were delivered, look at the liver here and compare it to the liver here, and all these spots, the tumor, they're not there, or to a large extent they're not there. And notice how much different the size of the liver is compared to the pre-treatment liver. And in fact, the kidney is now able to pop up into view, and it was not able to before because it had this big tumor blocking it. And so, it was one of the early success stories. Now, what we know from NETTER-1 and other trials, very large European retrospective trials, is that we see about a 20% to 40% partial response rate, which is good. Many people, and this is important, and because we know that when disease is stabilized, the outcome for the patient is just about the same as it is when the disease demonstrates a partial response. So we tend to think about these individual patients together in terms of how they're going to do after Lutathera. But we still have this 20% that don't respond, and I'm going to get to that in just a few minutes. So I had mentioned Dr. Strasberg, and our NETTER-1 team published last year the further follow-up, and the progression-free survival compared to the original NETTER publication in 2017 stayed about the same. Big difference between the lutetium-treated group and the control group treated with high-dose sandostatin. However, a little bit disappointing that the overall survival depicted here, and the red line is the overall survival of the lutetium group, and blue is the survival of the control group. There's certainly a separation you can see in the survival curves, but as you get out to 7 or 8 years now in the follow-up, the overall survival winds up being somewhat similar. Toxicity, just wanted to briefly touch on it. As was mentioned in the prior talk, the kidney toxicity is rather rare with Lutathera. A little bit more with the lutetium agent, and that probably has to do with the length of path of the beta particle when we use yttrium. The hematologic toxicity, we see the NETTER-1 trial, this is consistent with our experience. We see about 2 to 3% of cases where the neutropenia, particularly the thrombocyte, the platelet count in particular, becomes a problem, a clinical problem. We have to stop the treatment or change the amount of the Lutathera, maybe not give as many cycles. And then, of course, there is this issue of the myelodysplastic acute leukemias that develop in a small percentage of patients important to note that the myelodysplastic syndrome occurs 3-ish years after treatment on average, and then the acute leukemia more like 5 or 6 years after treatment. Let's go on. I'm going to, this actually is a picture of a radiation-induced damaged part of the kidney called the glomerulus. Again, it's uncommon with Lutathera. The red-orange represents essentially blood clots that have developed in the little vessels of the glomerulus. And that's where we see the rare but occasional toxicity from Lutathera. And I point this out because we think maybe, we think with some good reason, that the alpha treatment will not cause this kind of toxicity as we do sometimes see with the Lutathera. How are we doing on time? We're pretty good. Well, I may go a little bit over, but tell me when I'm getting close, and I'll stop. Okay, thanks. So a little point about the most recent FDA release about Lutathera and treatment in patients with kidney dysfunction. They want us to be really careful when the GFR is less than 40, and they typically don't want us to treat patients with a GFR of less than 30. And that may correspond to creatinine level of maybe around 3. It depends on the patient and so forth. However, at Iowa, we do occasionally treat patients. Well, we've treated one patient for sure who was on dialysis with Lutathera, and we do it, the GFR, the natural GFR of the patient be around 0. They're on dialysis, but we do it, and we did it safely in a patient by using dosimetry to guide just how much can be tolerated, how much of the Lutathera can be tolerated in treating a patient who has kidney failure. I'm going to go ahead and skip that. So now, how do we find this 20% of people that aren't going to respond to the standard Lutathera treatment paradigm? Can we do better in saying, this individual may not respond at all, we need to look at other forms of therapy? And I'm going to mention a couple of ways that we think we can do that. And one of them is by looking, and this is sort of a poor man's dosimetry, essentially, by looking at the tumor uptake on the gallium PET scan. Another PET procedure that we think is going to be helpful in better selecting individuals who can, who will respond to Lutathera is the FDG PET scan. And I know at Case Western they're doing studies, interesting things that are going to come out. Others have also pointed out there's a lot of enthusiasm for maybe using FDG to help us find those individuals unlikely to respond to Lutathera. Here's an example of just using the SUV, which is sort of the semi-quantitative, not highly accurate, but it's reasonable approximation of the dose to the actual radiation dose to the tumor. And as my eyes fail me and my memory fails me, I can't remember, I'm not sure. I just know that this SUV is around 40 when I went through the slides earlier, but I can't see it now. Hopefully you can. So it's a high SUV, means it's going to be sort of a high radiation dose. And this is the pre-therapy, pre-Lutathera scan. So these are high SUVs. And this is the post-Lutathera exam, and you can see that the two tumor sites are virtually absent in terms of the PET, and then on the CT after therapy, the tumor sites are virtually absent as well. So excellent response with this high SUV. What about a patient, and this is from a small series, again, with lower SUV? And I think we have an SUV here of somewhere around 15. Again, I apologize, I can't say, it was about 13. Jim is younger than I am, but not by much. And he can probably see, is that 14? 14.7. Thank you. You would be a good radiologist, not just a great, by the way, great surgeon. We look at the response, and the response for that tumor, this one right here. Again, you actually look at the image, you say, oh, well, that looks about like just, it's dark and it's red. And that's a little bit misleading here, the way they have formulated the image, but the uptake really is quite a bit lower. And then on the post-therapy scan, you can see here's the tumor on the CT before, here it is after. Didn't really respond very well at all. In fact, it got worse. This was a patient of ours. That SUV I can see, 42, that's pretty high, similar to the prior study, in the big blue circle there. And here are the pre-therapy tumors on the CT for that patient, and very good, no more tumor. High SUV, no tumor. So we think that, and here's another study, and the responding patients in this study who responded to the Lutathera are here, and the average SUV of the responders is here. It's about 30. Again, this is sort of a poor man's radiation dose. And here are the non-responders, and the average SUV of the non-responders, it's about 18. And they said, well, I think we ought to be thinking about using a cutoff around 16 or 15, and patients that are less than 15, certainly less than 10 SUV, probably are not likely to respond. Going to skip that one. I did want to mention the FDG, and you can see here that this study found that tumors with high versus low FDG, the high FDG tumors did not respond well. The low FDG tumors did respond well. Here's another study. And I have to be a little careful here. If I go back, these are just, I apologize, these are not Lutathera treated patients. These are all patients with all treatments, and they just found in general FDG predicts who responds well and who doesn't. Here is a group of Lutathera treated patients, and they separated the Lutathera treated patients into FDG negative, which is this line, and FDG positive, which is this line. And you can see that when you're treated with Lutathera, if your tumors are largely FDG positive, you don't do as well as if your tumors are largely FDG negative. The good news is grade 1 tumors are largely FDG negative. So in any event, FDG may be helpful. This is a blood, let's just say a blood test, genomic signature in the blood. So it's messenger RNA mostly. It's a blood test that Dr. Lisa Bodai developed with her group, and I won't go through each of these, but it basically says, this blood test helps us to predict who is good. Now, it's not widely used, and I don't know, I think there are financial issues involved, but they did get pretty good results predicting responders to Lutathera with this simple blood test. So how do we make PRRT better? What's coming in the future? Well, a big area is let's combine Lutathera with drugs that radiosensitize the tumor cell to the effects of Lutathera. Immunotherapies are an exciting area for combining with Lutathera, and there are other drugs, medications, chemotherapy that are being studied in combination with Lutathera to help improve the result. I want to just show you really clear. Sometimes we think it makes sense to inject the Lutathera directly into particularly people who have dominant liver disease, directly into the hepatic artery. And then alpha, we talked a little bit about alpha part. That's certainly an interest of ours at Iowa. And then I'll mention briefly STR antagonists as a distinguishing targeting molecule from agonists, which is what Lutathera is. And then dosimetry that we've talked a little bit about already. So we talked about dosimetry a little bit. Tumor dosimetry, SUV of the tumor, sort of a poor man's dosimetry. This is a group of patients with liver tumors, but they're not neuroendocrine tumors in the liver. But it's such an elegant, well-designed, well-done study with such a definitive answer about tumor dosimetry and the ability to use it to select patients that I wanted to show you these two curves, survival curves. And what the authors found in these liver tumors was that if you get to a certain target dose in the tumor, and in this case it was 205, but to get to 205, and you're going to have a really good survival course. If you don't get, in this particular type of tumor, to a tumor dose of 205, the survival is much diminished. And it really emphasizes what we sort of have known for a decade, or suspected, I should say suspected for a decade, and that is that there's going to be a radiation dose different for different tumor types that will define whether the tumor is largely sterilized or is likely not to respond. Along those lines, specific to neuroendocrine tumors, this was a trial that was done where the author said, well, let's just treat everybody until they get a certain radiation dose to the kidney. If you give 4 cycles of Lutathera, the average individual, the radiation dose to the kidney is actually quite low and not nearly where it can be tolerated. So these authors to say, well, let's treat everybody up to this safe level. And what they found, we use this 23 number, 23 gray, 23 number is safe. We know that that's safe. And they gave everybody enough Lutathera to get to 23 gray in the kidney, and then they compared that to individuals that just got the standard 4 cycles of 200 millicuries. And what they found was that survival was better overall in the individuals who got the 23 gray. Same with progression-free, but overall survival, let's just look there. The 23 gray patients had a better overall survival than those that were just treated with standard 200 millicuries. On average, just to throw some numbers, on average, when you get the 4 cycles, 200 millicuries in each cycle, the kidney dose is somewhere collectively around 10 or 12. Well, the kidney can tolerate a whole lot more. So keep that in mind. Dosimetry, I think, is a potential way for us to improve that response. I'm going to pass on that. Let me just mention, so we use personalized dosimetry to combine Azedra, which is the MIBG targeting agent. This is an FDA-approved drug for pheochromocytoma. We combine the Azedra with Lutathera, and we use personalized dosimetry to figure out how much of each to give to a patient. And that's a clinical trial that unfortunately with COVID, we have not enrolled anybody for the last 2 years, but we're hoping to be back in business here soon. I think in the interest of time, and I want to get to, so I mentioned, what about just injecting the Lutathera directly in the hepatic artery? And I think you can see here the hepatic artery, that's where the tumors in the liver get that's their primary blood source. The normal liver doesn't get or gets a small amount of blood from the hepatic artery. So let's just go directly into that artery and then see about whether or not we can improve the targeting of the liver tumors. This was a set of images over a period of time from a study. These are, by the way, our octreoscan pictures. These are the images from the individual after he was given an intravenous injection of octreoscan. Look at the images after he received an intra-arterial injection of the octreoscan, and you can see the much darker, you can see more tumors targeted when we give the intra-arterial versus the IV injection of the Lutathera. There's actually if you go to clinicaltrials.gov, there is a trial ongoing in which this particular treatment is given, Lutathera is given intravenously, and we also have a trial at the University of Iowa where Yttrium-90 Dotatate is given intravenously into the liver. I just wanted to mention quickly the potential advantage of using a targeting agent which is an antagonist of the somatostatin receptor. And the deal here is the agonist, which is Lutathera is an agonist, and that just means that it stimulates the receptor. The antagonist inhibits the receptor. And the deal with the antagonist is there's just a lot more, for various reasons, of the receptors available to the antagonist than the agonist. And here's a scan published very recently. Look at essentially the Dotatate. It's not quite the same, but you can see the PET scan with our standard agonist, Dotatate. In this case, it was Dotanoc. And then look at the scan in the same patient after the antagonist is given to the patient. In this case, now not all cases are this dramatic, but this one was, so I picked the most dramatic. And then the patient was actually treated with the lutetium-labeled molecule antagonist, and the patient responded very nicely. So antagonists may be a big part of the way in which we improve targeted radiotherapy. I probably am pushing the time, right? I suppose I'm getting on there. All right, I'm going to, so let me just real quickly point out that if we can improve the blood flow to these bigger tumors, where the blood flow is usually not that good, we can improve the delivery of Lutathera. And this really restricts our ability to treat patients with Lutathera in many tumors. Better blood flow. There are a number of agents, some of them were discussed in the prior presentation, which can do that and which maybe makes sense to combine with Lutathera. We can upregulate the receptors. At Iowa, we use a drug called varinostat to upregulate the number of receptors, and we see about a 20% on average increase in the targeting when we do a PET scan, gallium PET scan, when we use this drug varinostat to increase the number of receptors. Down here, so if we give chemotherapy in combination with Lutotherapy, the two agents act together to better damage the DNA molecule. And finally over here, we can give agents that impair the repair of the damaged DNA, which does take place in cancer cells. So the radiation damages the DNA, and then we can give a drug that stops the repair process and the tumor cell dies. I'm going to move over on that. Here's a trial with one of those the repair impair agent in combination with lutetium dotatate, and this is again in clinicaltrials.gov. Okay, can I take 5 more minutes? Is that okay? I guess I didn't bring my my water bottle. Well, so this is the slide I'm going to present that starts alpha therapy. So we've been excited about alpha therapy for a long time. Wish we had done more and sooner. But the deal with N, we certainly excellent discussion. I don't want to rehash too much. But the idea is that alpha, these are big particles with lots of energy, and they damage the DNA much more efficiently than the small beta particles, and as depicted there. The other thing with the alpha particle therapy that's so appealing is that if you look down here, the orange spheres represent tumor, let's say in liver, and here's the gray, normal gray liver spheres. The short range of the alpha particles in this little, thank you, appreciate that. The short range of the alpha particle, it's not long enough to get out and damage the surrounding normal tissue, like perhaps in the liver. And this was published back, a small series, 2014 maybe, and you can see the tumors in the liver, the very bright light areas here in the liver, and this patient has been treated with Lutathera already, and then he was treated with bismuth 213, which is an alpha emitter, targeted, same targeting moiety, of course, and look at the tumors. Now remember, this is after failing Lutathera. It was a small series, but it really caught, I think, our attention and made us realize this could really be a big deal. The whole idea, I showed that glomerulus that had the damage from the Lutathera. The idea is that glomerulus is this little area where the kidney does its filtering up here. Our treatment agents bind to the tubules of the kidney, and with a beta particle, the beta particle can reach all the way to the glomerulus and damage it. Now again, it doesn't happen very often, only a few % of patients. But the alpha particle, it's going to start out here in the tubule. It's not going to make it to the glomerulus. So we think, and so far so good, in very limited experience, the glomerulus probably will be spared virtually completely with alpha treatment. Actinium-225, that's going to be one of the big alpha treatment agents, and there are numerous alpha particles that come out of the decay chain of actinium-225. Now, here's an actinium-225 treatment of prostate cancer, and we're actually farther ahead with treating prostate cancer with alpha, but in any event, you can see the failed treatment with lutetium in the prostate cancer patient just didn't do it. And then here, after a couple of cycles of actinium-225, the tumor's gone, virtually gone. But actinium-225 is being used, and here's an example from a couple years ago. A group in India, which now has a fairly large experience, 100-ish or more patients, using actinium-225 in patients who are refractory to the lutetium agents. And you can see the baseline uptake here, quite a few lesions throughout bone, liver. Here's a sagittal slice. You can see the vertebral bodies. And then here, after a couple of cycles of actinium, the neuroendocrine tumor is melted away. So exciting, and I think really is the now. But I have to mention lead, because lead is what we're using at the University of Iowa. We have a phase 1 trial funded through NIH, which is we haven't enrolled yet, but we're close. And the lead-212 decays as well through a series of both alpha and beta decays, both. So you kind of get both with the lead-212. And the nice thing about lead-212 is that although you can't really make very good images of it, unlike Lutathera, when we saw the image after Lutathera, where you could see the tumor sites that were targeted, we just substitute the 203 radionuclide, which does not emit alpha, but it's the same chemistry, it's lead. The 203 gives us a gamma ray that we then can image. So it's a real nice, what we call theranostics pair, and that's what we're using there here at Iowa. And I won't go into it because the AlphaMedix trial was already mentioned. It's in phase 2. These are, the AlphaMedix folks are treating patients who are, as was discussed, radionuclide naive, no prior Lutathera. Our trial is in patients with prior Lutathera, have failed or recurred, as is another trial with actinium-225 sponsored by Raise Bio that is now, it's a interesting, it's a phase 1, phase 3, now open at a couple of sites. We're lagging, we're trying to get there, but which I think is a very exciting trial too, because it's probably going to move the actinium alpha agent fast, because the FDA has allowed this group, it's really, I think it's great, to go from a phase 1, let's show that it's safe. As long as you show it's safe, jump right to a phase 3, bypass the usual phase 2, and hopefully get it FDA approved. So, this is the trial. I think we'll just call it. Oh, there's our trial. A lot of I tried to make it look complicated so it makes us look smart at Iowa, and but we're going to be. The one thing I would mention about our trial, look, all those boxes, again, we're using individual dosimetry to guide us how much to give of the lead-212. So, and with that, thank you very much. My daughter lives in Ireland for the last 15 years. She married a wonderful Irish lad from Galway. If you've been to Ireland, be sure to go to Galway. And I love the Irish. I love staying there. And this slide reminds me so much of my in-laws and the people I've met in Ireland. And I just sort of love the attitude. I try to. So I'm the panicker. So I panic. So I'm trying to learn from them a little bit. Thank you all so much.